Okay, we're going to talk now what I think are 10 ultrasounds that every emergency physician should know. I base these on all kinds of various random reasons, which don't have a lot of evidence or logic behind it. But hey, I think, in my best opinion, that this is the kind of stuff that every emergency physician who practices would definitely benefit from if they had the knowledge on how to do these ultrasounds. So we'll start off with pelvic ultrasound, and there's a couple reasons I think this is important. The first reason is this. Here's a typical patient who comes in, a 22-year-old female who's got mild lower abdominal pain. She's got no vaginal bleeding. Her LMP was 6 weeks ago. Her urine preg is positive. Her physical exam is sort of not helping you very much, and you know that on every single one of these patients, you got to check a UA, you got to check a serum beta HCG, and every single one of these patients needs an ultrasound. Failure to order an ultrasound, of course, is breaking with the standard of care. And so, unfortunately, we don't have a crystal ball. We can't, see into their belly without using an ultrasound machine. And this is just to kind of bring up what we used to do. We pulled this data right out of our patient training system. And zero, order an ultrasound, verify with the radiologist, and then we'd order a beta HCG because the radiologist wants to order HCG. And the beta result would come back an hour or 3 minutes later. And then we'd argue with the radiologist about the beta HCG and why, we would argue with us about why they weren't calling an ultrasound technician at, after hours for beta 400, and we were trying to explain that we don't care that it's below their discriminatory zones. What we care about is the fact that the patient may have an ectopic pregnancy. And ectopic pregnancies don't make normal amounts of beta HCG. They finally call the sonographer back, sonographer turns the page, and they know they've got exactly 45 minutes of contract to come in to the emergency department. And when they get there, they do a comprehensive ultrasound. They fill the bladder, they transport the patient down to ultrasound, and then the radiologist takes a look at the films. They see a live intrauterine pregnancy. We update the patient, and then the patient goes home from the emergency department 3 hours and 51 minutes after they arrived. Now, this is really easy to get around if you know ultrasound, because you can do your own pelvic ultrasound. This is an endovaginal ultrasound showing a live intrauterine pregnancy there, and with a little heartbeat flickering along, a little gestational sac, yolk sac. This is all the findings that the patient actually has a live intrauterine pregnancy, and basically you can save yourself a lot of time by just doing the ultrasound yourself. And about 3/4 to 80% of the time, you see you see the signs of an intrauterine pregnancy, and you don't need to do much else except send the patient home. And at least in my hospital, we have a very young patient population, so we end up seeing patients with complications of first trimester pregnancy at least 2 to 4 times a day. And so when the beds start crunching, and we don't, we're holding all these patients waiting for admissions, and we're trying to turn over our few beds as fast as we can, this time difference becomes important when you multiply that several times a day. Here's another reason why I think it's important to learn pelvic ultrasound. This is a patient who came in during my fellowship who survived. I smudged her face out here so you can't see who it is, but this was a woman who came in basically having what we thought initially was an asthma attack. The paramedics showed up, and they found this woman out on the front lawn who was bradycardic, hypotensive, and cyanotic. Well, when she got into our emergency department, she was actually in pulseless electrical activity, and we weren't really sure what was going on. We knew that, we heard that she was having an asthma attack, but we were bagging her after intubating her, and her lungs were clear, and she was really easy to bag, so we figured maybe that's not it. And so we thought, she was found outside, maybe she was hit by a car, so we do a fast exam, and on the fast exam, we see, here's the kidney, this is the liver, this is an old scan, so it's kind of hard to read, but this is the fluid sitting here in Morrison's pouch. And so we get very excited when we see this, that she's got a positive fast exam. And we do a good secondary survey, and we don't see any other signs of trauma. No ecchymosis, no bruising, no abrasions, nothing. And so then we start to figure it out. Well, this woman of childbearing age with fluid in Morrison's pouch, maybe she's an ectopic pregnancy. So we go ahead and we do an endovaginal ultrasound. You can see right over here there's blood actually actively bleeding, extravasating, if you will, from this region, her pelvis. And this is all blood here. All this other stuff is blood here in her pelvis. And, you know, we kind of put it together that this is a ruptured ectopic pregnancy, and we call OBGYN. And before we even have a pregnancy test back, she's whisked off to the OR, and she survived. And so those are a couple of good reasons I think it's very important that every emergency physician should harness the power of their ultrasound machine. Now, we'll switch gears here a little bit and talk about vascular access. And if you talk about the Agency for Healthcare Research and Quality, you know, they're really into the latest research that comes out to support any kind of change in our practice, and they came up with the fact that there's this paper that said making healthcare safer, critical analysis of patient safety practices, that putting central lines under ultrasound guidance really helps to avoid complications. They did a big meta-analysis of all the data out there, and they came out with this recommendation. And so you can also use it for peripheral ultrasound access, vascular access. And I find that central lines are actually much easier to do under ultrasound than peripheral lines. Peripheral lines are actually pretty challenging. But you know, there's recent studies that show that you can actually do this quite effectively by using ultrasound, even in very difficult to stick patients like IV drug users and obese patients. You can use ultrasound to localize a good peripheral vessel and access the vessel under direct ultrasound guidance. And what I mean when I say that the peripheral guidance is harder than central access is because the peripheral lines have very, very small caliber veins, and to thread a needle down into that vein, I think, is more challenging when those veins are really small. And so once you get good at peripheral lines, I think you'll find that you get much better at central lines using ultrasound. And you want to use a 2-inch long angiocath. This is just an example here. This is the shorter ones here, the 1.16-inch long angiocath. This is a 1.88-inch long angiocath. You can see how much longer it is. That's because, you know, the difference here is that we've got a transducer about this thickness on the patient's skin that's taking up this amount of space, and so you need a little extra throw to get the needle into the vein. And when you thread the catheter, it's got to go a little bit further, and you wouldn't want the catheter to using a shorter catheter, it could fall out if the patient moves their arm around, if you only had just the very tip of the catheter in. Over here you get much more of the catheter threaded into the vein. So you want to use longer angiocaths, ideally a 2-inch long angiocath. This is a really long one, 2.5 inches long. You know, you're starting to get into towards the PICC line world, but that's the ideal. Longer angiocath is what you want to use. And so once you obtain vascular access, you can set the transducer aside and then thread the catheter the way you normally would. And so this is just a schematic diagram of the various vasculature that you can cannulate. This is the cephalic vein. It's obviously very superficial, and then the deeper stuff is down here. The basilic vein is seen down here, and then eventually these come together where the median basilic vein comes together here with a median cephalic vein here. And so any of these are fair game, I think, for doing vascular access. If you need to go a little deeper, if you're not having a lot of luck over here peripherally, you can definitely go deeper, and you get up here into the brachial vein, actually, a very deep structure. But that maybe that's all that's left if you have somebody who's got chronic needle sticks for either IV drugs or medical procedures. One thing to keep in mind is that veins should easily compress. Okay, here's the artery next to it. The vein is easily compressible. Now that's critical because you see a black circle on the screen, you might think, oh, I'm going to stick that black circle. No, no, no. You want to come over here to where the compressible structure is. The other thing to keep in mind is that as long as the vessel is centered on the screen, it therefore must be underneath the center of the probe. And this is the most important concept, if you will. So as long as I center that vessel on the screen, I therefore only need to aim my needle towards the center footprint of the transducer. And that's really all there is to it. It's a very, very straightforward concept. It's a better idea to hold your hand over the catheter. That kind of helps advance it rather than underneath the catheter when you're doing ultrasound guidance. That's a better technique. So basically what we're doing here is just centering the vessel, and then you'll see the needle come right in here. See, there it is. Boop, and then we're in. So you compress, and then you center, and you aim for the center of the probe. Pretty straightforward. Now, another ultrasound I think is very helpful is for abscesses, and I call this the abscess study, the applied bedside sonography for the convenient evaluation of superficial soft tissue infections. A study we did where we had about 18 cases which ultrasound disagreed with the clinical exam about whether or not somebody had an abscess versus cellulitis, and the ultrasound was right 17 out of the 18 times for a significant p-value, not surprisingly. And basically this is what cellulitis looks like. Looks like cobblestoning. We can see these hyperechoic islands here of cobblestoning. Don't put a needle in that. That's cellulitis, as opposed to this, which is an abscess. And you can compress this swirling pus that swirls around like that. This is what an abscess looks like. This one truly does need surgical, incision and drainage. Sometimes you can see how they could have lots of other islands underneath that connect up, and you may need to, if the abscess is large enough, you may even consider referring some of these to surgery if they have a lot of pockets and things that would require lots of invasive drainages. So this is one way they can even help disposition the patient. Here's another reason I use ultrasound. And sometimes when you do an ultrasound, it's you get a sort of a surprising result, one that is that's not what you expected. In fact, I make the joke sometimes that I could, if there was a journal called the Journal of Unexpected Ultrasound Findings, I could publish in it all day long, because I do stumble across things all the time with ultrasound. This was sort of one of those situations. This was a 70-year-old male who came in with a choking episode. The bystander comes along, does the Heimlich maneuver, the paramedics get there, and the guy wakes up. And talking to this guy, he's got stable vital signs and everything, and other than a history of hypertension, he was, didn't really have any other medical problems. He was doing pretty good, except, quote, where that guy squeezed me during the Heimlich maneuver. Well, you talk to the guy a little bit more, and it sounds like maybe he actually syncopized rather than had a choking episode. Kind of hard to tease these two things out sometimes. So unexplained syncope and a guy like this with a history of hypertension, of course, equals bedside ultrasound. And not surprisingly, we found a very large abdominal aortic aneurysm on this guy. Or surprisingly, actually. And so this is what it looks like here. So this is a guy who came in with a choking episode who later went to the OR that night for a symptomatic abdominal aortic aneurysm. Symptomatic in the sense that he syncopized. And, these being 1 centimeter hash marks, he's got 1, 2, 3, 4, 5, maybe 6 centimeters of aneurysm. And the reason you don't feel these on physical exam is because of all this clot right here. So this is the true lumen. This is all this congealed stuff back here. This is the clot. And you won't feel that on the physical exam because, you won't feel the pulsatility of the aneurysm because the clot dampens the pulsatility of it with all of this material here, this congealed material. So yeah, it's pulsatile down here, but that doesn't transfer so much towards the skid line. So that's why we miss these on physical exam about half the time. Here's another reason, and that's the central venous pressure. You can estimate or qualitatively using ultrasound. Basically, where the inferior vena cava dumps into the right atrium, at that location there is a nice place to see the change in the IVC diameter with respiration. So as you breathe in, your IVC will collapse. Okay, and if you have high intravascular volume, it won't collapse. Whereas if you have low intravascular volume, as you inspire, your IVC will collapse. And if it collapses by more than 50%, it's said to be a low intravascular volume, or low CVP. If it collapses by more than 50%, it's said to be a high CVP. And all also depends on the pre-inspiratory diameter. And so you measure this pre-inspiratory diameter somewhere around here. This is the hepatic vein dumping into the IVC. This is the IVC dumping into the heart. About 2 centimeters distal to where the IVC enters, I should say where the hepatic vein enters the IVC, is the location at which you want to observe the IVC for collapsibility during respiration. The way you do this, you take the indicator, aim it towards the patient's head, and you do a parasagittal to the right axis. And so here we are. This is the IVC here. The patient's breathing in and out, and there is no change in diameter. And this looks like it's about probably greater than 2 centimeter IVC. Here's a hepatic vein draining in here. You come over here about 2 centimeters. Right about here, I'd be observing it. And there's really no change with respiration. So I would say this patient has a CVP greater than 10. And, you know, in the setting when you're trying to resuscitate somebody, if you've got a patient with who you're resuscitating, it's just one more piece of data to say that in a plethoric IVC, what could be going on? They could have fluid overload, or they could have a blockage in a pulmonary artery, like with a pulmonary embolism. So it's just something to keep in mind in your algorithm while you're resuscitating somebody. So if I have somebody who's got a lot of respiratory distress, I'm debating between a PE and pulmonary edema, and this is something that would lean me towards either one of those diagnoses. To differentiate between those diagnoses, I want to look for the signs of pulmonary edema on ultrasound, which are B lines. And we're not going to talk about that right now, but that's just something that we could also do at the bedside. So here's a collapsible IVC, and we see here that after inspiration that collapsed way down like that. And so this is somebody who's got a low volume status. Here we are here now. The patient's inspiring and the IVC collapses all the way down. The walls practically touch. Again, here's the hepatic vein coming down 2 centimeters back from that. Got the probe in a right parasagittal plane, indicator towards the patient's head. So low CVP here. So in this case, you definitely consider giving fluids. How about this patient? There's another reason I think ultrasound's helpful. 26-year-old female bus driver. She comes in. She's got shortness of breath and chest pain. Now, she's on oral contraceptive medications. She's a heavy smoker, and she's sick. Her vital signs are terrible. She's tachycardic, hypotensive, tachypnic. Her lungs are clear. She doesn't have any murmurs. She's sort of tacking away there. And as I'm talking to her, she's grabbing my arm and actually saying to me, "I feel like I'm going to die. Doctor, don't let me die." And, you know, it's a little freaky when a 26-year-old person says that to you. I don't care how long you've been doing this, especially when they look really sick, like they are going to die. And so the signs of, I mean, clinically, this patient, I thought, had a pulmonary embolism, and we know that the American College of Emergency Physicians in a guideline recommends considering the use of thrombolytics in the setting of known pulmonary embolism if the patient has these types of vital signs, shock. And so I had the nurse go get the TPA box, and she opens it up. She's drawing up the TPA, and the dad's in the room asking me, you know, is there some way you can confirm that this is a pulmonary embolism? I said, well, you know, we could get a CAT scan, but, you know, I don't want to send her down to the CAT scan with these vital signs. I think, you know, we just have to go sort of on a clinical hunch. But then I remembered that, you know, we could do an ultrasound, and on ultrasound, pulmonary embolism looks like you just have a gigantic right ventricle. In other words, normally when you compare the right side of the heart to the left side of the heart, the right side is about 2/3 the size of the left side. So the RV should be about 2/3 the size of the LV in a normal patient. But with RV strain, which you see with massive pulmonary embolism and also pulmonary hypertension, the right ventricle gets very large. In fact, it approximates the size of the left ventricle. So keeping that in mind, I plopped the probe down on the patient, and I saw this. Now, I looked over at the nurse, and I said, "Excuse me, did you push the TPA?" "No?" "Good." Because that would have been the exact wrong thing to do. So this is the pericardium out here. This is an old ultrasound, but this is the liver seen up here. And this is the heart down here. The myocardium's down here. Pericardium is here. This is a massive pericardial effusion. In fact, it's tamponade. How do I know? Because the heart is swinging back and forth. And if you did an EKG, you would likely see what? Low voltage EKG, exactly, because of all this fluid here. It's hard for the electrical impulses to make it all the way to the skin line. However, sometimes you get lucky and you see the electrical alternans, and this is why, because the heart swings back and forth. But the most common finding of pericardial tamponade on an EKG is actually low voltage EKG. So this patient did not get TPA. She got pericardiocentesis, and we drew off 700 cc's of fluid out of her pericardium, and it turned out she had lupus. And you know, if you took a little better history, you'd probably realize that. But at the time, you know, kind of dealing with the low amounts of data and time that we have in the emergency department, I think this is another really good reason to learn how to use ultrasound. Now, pulmonary embolism would have looked like this. Okay, so this is an apical 4-chamber view. This is normally the left. This is the left ventricle here. I say normally because normally this left side should be bigger than the right side, But in this case, this patient has a dilated RA and RV when compared to the left ventricle in the apical fourth chamber. In the parasternal lung, same patient, the LV, what we see here are kissing papillaries. The inside of the left ventricle actually comes together and makes contact. The posterior wall makes contact with the intraventricular septum. That's an empty LV. That's a hyperdynamic heart with an empty LV. That tells you that the fluid's not getting there through the lung vasculature because it's all getting stuck. The RV is trying to pump against a pulmonary embolism. The RV is very dilated here, but it can't get the blood over to the LV. Now, here's another ultrasound I think is very, very helpful in my practice. We know that when patients come in with leg swelling, we order an ultrasound on them, there's a greater than 95% chance that the ultrasound is going to come back normal. And we do keep a lot of these patients here. Sometimes we even, in some practices, if the patient comes at night and they can't get a bedside ultrasound or they can't order one from radiology, they actually administer some type of anticoagulant, and the patient gets the study in the morning. And I don't know about you, but I certainly wouldn't want to be exposed to the anticoagulant if I didn't need it, especially because there's a 95% chance that I'll have a negative ultrasound. And a study was done, published in JAMA, comparing the full technique to the limited technique, which is only looking in the FEM and the POP. And there was 2,100 consecutive patients. It was randomized, prospective, multi-center. Pretty decent methods, and it turns out that there was no difference between these two groups at all. And so that helps me remain confident when I do my 2-point bedside ultrasound, looking in the FEM and the POP for a DVT. And this is what it looks like here. Here's the superficial deep femoral artery. Here's the common femoral vein prior to compression. Therefore, this is the left leg. We aim the indicator to the patient's right. This is medial. The way I remember that the veins are medial to the artery is that venous rhymes with something more medial, penis, venous penis. It's closer to the penis, and that's my way of remembering. I know there's other less vulgar ways to know this, but this, for some reason always helps me out when I'm on either side of the leg and trying to decide which side I'm on. So this is the course that the femoral vein takes. Again, we check up here in the proximal region, about 5 centimeters distally to the inguinal ligament, and then back here in the popliteal fossa. And in the popliteal fossa, we're looking posteriorly. This is the superficial skin here. This is the popliteal vein, popliteal artery. What we're doing is we're compressing the vein, so the vein compresses here, and the vein should disappear as we compress. And the way I remember this is in the POP, the vein comes to the top. And here's the very proximally here is the common femoral vein. We see the common femoral artery. In fact, we even see the saphenous vein here. This is without compression, and this is with compression. The venous structures totally compress out of the way, and we don't even see them now. And that confirms that there's no DVT at that location. You could also do a video format where you're checking, demonstrating this under video, and I think that really demonstrates that under multiple locations there's no compression. One more reason why I really like the video, not just for the heart but also for DVT studies. So I actually archive all of my stuff in video because I think video is a much better picture of what's going on. Now, this is what it looks like when you do have a clot. Here we are compressing. These are the arteries. Here's the vein. We're compressing. There's no compression there because there's a clot there. Now, once you identify a clot, you don't want to keep compressing it. You want to just capture this, again, on a video format, I think is best, and show it to one of your colleagues. Now, here we are on the POP, and again, the vein comes to the top in the POP. Here's the artery. Here's the vein. And as long as it's good compression, there's no clot there. Instead, when there is a clot there, here we are compressing. You push so hard sometimes that even the artery tends to compress. You don't want to push that hard because you don't want to dislodge these things. But we can see here, here's the vein, here's the artery. The vein is not compressing. Okay, we're going to move on a little bit now and talk about the heart. And I think this is a really important ultrasound to know because it can help you with your resuscitations. So here's a 74-year-old guy. He came in, he was short of breath for 1 day. And the question is, why? And another question you often ask is, why is somebody hypotensive? And you can answer these questions using ultrasound of the heart. And so anytime I've got a patient with shortness of breath or hypotension, my first instinct, because I've had so much, it's changed my practice so much, my first instinct is to reach for the ultrasound machine every single time, because I get so much good information. So this is the left atrium, this is the left ventricle, this is the aortic outflow tract, this is the right ventricle. This is called a parasternal long axis. And a couple things here. One is the mitral valve. I'm looking at the anterior leaflet of the mitral valve. It should come up and smack the septum. And I'm also looking at the posterior wall of the interventricular septum. They should squeeze together. And in this heart, neither one of those things are happening. Okay? So this mitral valve is not smacking the septum, and the septum and the posterior wall are not squeezing towards my arrow there. So in this case, this patient has poor LV function, and I know that I'm going to need to be very judicious with the use of fluids, especially if they have shortness of breath. Okay, so this patient may only get better when given inotropes to help that heart squeeze better, and have a very good direct visual evidence of that. See, because normally that mitral valve should come up and smack that septum. Can you see that there? I'm going to freeze this a little bit and show you how that happens. Okay. Boom, right there. See that? See how that mitral valve right up here smacks that septum? See how I'm doing that? I'm kind of going frame by frame here to show you that. That's normal. That's what you want to see. Okay? Now, let that play, and then I'm going to look over here at the interventricular septum and the posterior wall. Pretend you're a little red blood cell sitting right here, and you would get squeezed right out the aortic outflow tract, right? Because these two things are compressing, squeezing you right out the aortic outflow tract. Down here, though, we've got a couple problems. First of all, this mitral valve is not coming anywhere near that septum. Number two, the interventricular septum and posterior wall are not squeezing the red blood cells out of the aortic outflow tract. So just right off the bat, if both these patients had a blood pressure of 70, I'm going to give this patient fluids, and this patient, I'm going to be very careful with fluids and likely lean on inotropic therapy. So what do you think about this heart here? Blood pressure in the 70s. Do you want to give fluids or inotropes? Mitral valve comes up, smacks that septum. Posterior wall and ventricular septum squeeze together quite well. I'd be giving this patient fluids because they've got a normal LV function. How about this patient? Interventricular septum. Anterior leaf of the mitral valve. Not hitting that interventricular septum at all. Interventricular septum, posterior wall not squeezing together. This patient's got a very poor LV function. Be very careful with fluids. That's all. Parasternal long axis. My favorite view of the heart. So what about this patient? 56-year-old, 60-pack year history of smoking, known left ventricular ejection fraction of only 35%, comes in with shortness of breath. So right off the bat, you're worried about congestive heart failure. Or is there something else going on? Is it chronic obstructive pulmonary disease? Because he's got a 60-pack year history of smoking, and sometimes it's very difficult to feather out whether someone's in CHF or having COPD. And the way you do this is with ultrasound. It could not be easier to do this particular ultrasound. So this, I think, is definitely one of the top 10 ultrasounds that every emergency physician should know. And this is, you take a phased array transducer and you place it on the anterior chest. And if you see these lines right here, see these comet tails coming to the bottom of the screen, this patient's got fluid overload. This is what we call B lines. Just like on chest x-ray, you've heard of curly B lines. It's really the same thing. It's the fluid that's in the interlobular septae that gets this artifact. It's a comet tail artifact and extends all the way to the bottom of the screen. Whereas over here, if it's that patient you're worried about who could either have COPD or CHF, over here we see these lines right here, A lines. These are from the skin line to the first horizontal line. That distance repeats itself into the chest. And that's basically either normal or you can see it with COPD. So it's really the absence of A lines and the presence of B lines that confirms CHF And over here is the absence of B lines and the presence of A lines that we can cross off CHF off our list and think more about COPD. This is where you stick the probe when you're doing one of these lung ultrasounds. You put it anteriorly here, a little more inferiorly over here, and then more laterally here. Okay, so this is the anterior axillary line, posterior axillary line. And this is kind of what divides these areas. And this is, the sternum is right here, so this is just sort of right parasagittal to the sternum. So that's the question you're asking yourself. Do I see A lines or B lines? And again, the A lines are equally repeating distances that come from the chest wall down at the first A line we see here is the first artifact that we see here is called the VPPI, the visceral parietal pleural interface. That's where the lung is, the pleura of the lung is up against the pleura of the chest wall. And we'll see this sort of slide back and forth. Here's our rib shadows here. And then at that same distance that we had from here to here we see the A line. And that's normal. Or sometimes you can see that in the setting of a pneumothorax, if it's not sliding. Again, there's those distances there. They're normal. So air doesn't transmit sound very well. In fact, the air scatters the sound everywhere. But I love seeing this again. Here's the skin line. We come down. This is the VPPI. It's sliding back and forth. It's sort of subtle there. See that sliding right there? That's the lung up against the chest wall sliding back and forth. At an equidistance, I see another A line down here. I should say I see an A line. This is the VPPI. This is the A line here. And then an equidistance from there, I see another A line down here. And if you strain your eyes, maybe you can see another one down here. Okay, so this is in the normal lung. We see these A lines sliding back and forth. We'll also see A lines that don't slide in the setting of a pneumothorax. There's that VPPI, or the pleural line. And that reverberates back and results in A lines as an artifact, equidistant. So when fluid replaces air in those interlobular septae, we can see conduction now in the form of B lines. So we lost the A lines. There's no A lines here. It's just B lines. That's pulmonary edema. Couldn't be easier to do. It's kind of a hard thing to describe, and the physics behind it is sort of hard to describe, but it's one of those things where you plop it on the chest and you either see this or this. It's pretty straightforward in reality. The explanation makes it seem complicated, as you can tell as I'm struggling with it here. More B lines. Patient had them in all four quadrants of their lung, and this is clearly pulmonary edema. Again, a curly B line extends from the lateral chest down into the lung, and that's from fluid in there, interlobular fluid. And so when there's fluid there, the sound reaches that fluid, and you get that comet tail that extends all the way to the bottom of the screen. Okay, now here's another thing I think emergency physicians could all benefit from is for pneumothorax. It's because on a chest x-ray, I struggle with this all the time. This patient actually does have a pneumothorax, and the reason I struggle with this is because in a supine patient, it's very difficult to see a pneumothorax. You look for a deep sulcus sign. This patient kind of has one here, but that's about all you got. I mean, it's very difficult, which is why the sensitivity of a chest x-ray is really in the coin toss to 75% range. And this here is the same patient we just saw in the chest x-ray. They've got the pneumo up here. Of course, CT is excellent for pneumothorax. Picks up the smallest pneumos, but ultrasound is a lot closer to CT than it is to x-ray. In fact, you can see here for ultrasound to pick up a pneumo, when you use CT as a gold standard, is about almost perfect test characteristics in this study done with 176 patients by Blivis in the academic emergency medicine. So how the heck do you do this? When you did those B lines, when you're looking for B lines and looking at A lines, you use the phased array transducer. But when you're doing pneumothorax, you're going to use a linear transducer. It's just easy. You could use the phase rate, but I think the linear is so much easier to use. You're going to use that second intercostal space. You aim the indicator towards the patient's head in a vertical orientation in that mid-clavicular line, and you're going to have the patient breathe in and out about 4 or 5 times. And see, what's happening in here is that the sound when it reaches the ribs, there's a shadow there. But what you're looking for is the interface of the lung sliding back and forth. The lung, when it's up against the chest wall, when there's no pneumo, it slides right up against the chest wall. And the air in the lung impairs the transmission of the sound, but you can see the pleural interface and the sliding of the visceral and the parietal pleura against one another as the patient breathes. But when there's a pneumothorax, what happens is the lung then falls away from the chest wall, and when it slides back and forth, now there's no sliding, there's no interface there, and you lose that sliding because air is the enemy of ultrasound, and it separates the pleura, and you can no longer see it. The probe can't see the lung anymore. And so it's the loss of lung sliding that is the pneumothorax. So here's an example here of somebody who does not have a pneumo. Here's a rib shadow, here's a rib shadow, and this is the pleural line sliding back and forth. Okay, so that's what I mean by putting the probe into a sagittal view. So the rib is under the superior portion of the probe here, and the next rib is under the inferior portion of the probe. This might be rib number 2, rib number 3 here. And we see that common tail artifact sliding back and forth at that VPPI, or visceral parietal pleural interface. This patient has a pneumothorax. There's the ribs, there's the shadows, and we no longer see the sliding back and forth here. There's no common tail artifacts there. This patient's got a pneumo. Lack of lung sliding. That is the pneumothorax. What do you think about this one? A lot of tissue here in the chest wall. Looks like muscle. This is a rib shadow. This is a rib shadow here. And this is the pleural line sliding back and forth. You see that? So this patient does have lung sliding. There's no pneumo. Okay, well that concludes the lecture. We talked about the 10 ultrasounds I think every emergency physician should know. Pelvic ultrasound, vascular access, abscess versus cellulitis, looking at the great vessels such as the IVC or even a AAA, and looking for cardiac tamponade, looking at the heart not just for tamponade but also for a large right ventricle in the setting of a massive pulmonary embolism, and then look at it for contractility in terms of does the patient need more fluids or more inotropic support. Talked about DVTs and the compression, and also about pulmonary edema. It was sort of a confusing discussion, but I think you got the idea that when you see B lines, it's pulmonary edema. When you see A lines, there's no pulmonary edema. And with pneumothorax, the sliding or not, using a linear transducer, lung sliding equals no pneumothorax. Thank you very much.